So the background to this is, as you all know, we spend quite a lot per capita on healthcare spending, and our outcomes really are not as optimal in this province as they should be. So one of the purposes of the recent reorganisation was to set up a branch to set standards to help improve quality. Now, quality isn't the only part of the equation. We have to look at costs as well to truly appreciate value. And we thought that this would be a good opportunity to get the economic prospects, macroeconomics, cost-benefit analyses, etc., back into the level of consciousness of the ministry as we move forward. And so this was the rationale for having this series of seminars. I'm not going to say any more. I think this is an exciting program. The partnership between the Economics and Funding branch and the Institute of Health Economics is very strong. I was just saying to Chris, I realise how health economists are few and far between across the country and in the province. So I think we're lucky to have a captive group to help us inform this. So I won't say any more. I'll hand it over to Andy Chuck and he'll give you a few more practical details. So thanks very much. Appreciate you all coming today.
Just on behalf of Egon Janssen, our CEO, and Lauren Terrell, our board chair, just welcome you all here. We're just very delighted to be able to partner with AH and the universities to put on this series. I want to be succinct, but I just need to get through some housekeeping. So you'll notice that the camera is here, and this is for live streaming. But for those that are online, when we get to the Q&A, we will be sort of closing that off. As well, please register for the other sessions, because I think you have to complete 8 sessions in person for you folks to receive a certificate at the end from the IHE. As well, you'll be receiving an evaluation survey that can be completed online at the end of the sessions. So with that being said, I'm very happy to welcome Professor Chris McCabe from the University of Alberta. I'm not going to go through his bio. You have those in your hands. I think it suffices today that he is an internationally recognized leader, scholar in health economics. Very pleased that he's with the University of Alberta here. For those who don't know, he was actually a significant contributor to the recent update of the Canadian Agency for Drugs and Technologies in Health economic guidelines. So this is the guideline that economists are supposed to use in Canada when doing an econ eval, and he was a contributor to that. So Chris, thank you again very much. The floor is yours.
Andy, thanks very much, Alan. Thanks for the opportunity to come and talk to you today. So I'm going to kind of hopefully give you some insight into the conceptual value of health economics. I don't want to get lost in lots of detail. I'm pretty sure this is an algebra-free presentation. You'll all be relieved. You know, I know when an economist stands at the front, people think there's going to be those funny symbols up on the wall. Well, partly because it's so long since I did that stuff myself, rather than having bright young people do it for me, I don't like to put algebra up too often in case it confuses me, and I look as dumb as I am, really. So what I want to do, I want to introduce you to what is health economics, and then take a dash through some of the more interesting questions that we deal with. So what is opportunity cost? What do we mean by value? Everyone talks about value. Well, what do we mean by value? How do we know what something is worth? A really crucial question that I think is under-remarked in the policy world is understanding the difference between testing a hypothesis and making a decision. You lot are all in the world of making a decision. And people like me in our lovely ivory towers spend a lot of time testing hypotheses. And sometimes the misunderstandings and the failure on our part to be as valuable to you as we should be is because we think that testing a hypothesis is actually really helpful to you. And sometimes that's not. So I just take a quick example of why they're different and how that changes how we think about evidence, okay? Or should change how we think about evidence. Then I'm going to very quickly introduce you to economic evaluation, which is probably the component of health economics that you've all encountered the most, and how that is useful in decision making. And really, I'm doing that to illustrate that opportunity cost, bullet point 2, is not just an abstract concept, that it's a really useful mechanism that we can operationalize in helping you make better decisions, okay? And then finally, I'm going to flag up probably, one of my own hobby horses about uncertainty, the cost of uncertainty, the risk of making the wrong decision, and how economics, health economics, can actually help decision makers know when it's appropriate to say, actually, I'm going to hold off making a decision here to allow gathering of more evidence. This is a big question. This is an important issue, and I need to get the risk of making the wrong decision down to an acceptable level. And economics has some analytical methods that allow us to help you with that. So, health economics for policy making is about making decisions. It's about making choices. And economics is all about making choices. But it's not just about economic evaluation. So this is called the plumbing diagram. Sometime around 1983, at the University of York in the UK, which was the European sort of birthplace of health economics, really, and continues to be a major centre, the health economists there got together over a couple of days to try and agree what was the scope of this discipline that they were pushing out to the world. And it really is quite wide. The little bit that most of us think about as being health economics is just this box here. Box E, microeconomic evaluation of treatment. But actually, health economics starts with understanding the influences on health and thus the demand for healthcare. It's interested in what do we mean by health and how do we value it? What's the demand for healthcare? So the determinants of health is one of the things that feeds into the demand for healthcare, but also how much healthcare costs in terms of finance and time, and our ability to access people who can provide healthcare, the clinicians. That all determines, those things all interact to determine the demand for healthcare. What determines the supply? I mean, we spend a very large amount of money, and we have a huge infrastructure on healthcare in this province. But people in rural parts of the province would like more physical infrastructure to have the supply closer to them. And so actually these factors are all part of understanding the supply of healthcare. And there is, within our toolbox, there's a set of analytical processes that can help identify what's the appropriate, what's the efficient scale of supply for a given level of demand, given our budget and what we're trying to achieve. And in principle, there are markets in healthcare. Well, in principle, in practice, there are markets in healthcare. And understanding the interaction of the demand and supply factors gets us to understand where we are in the actual provision, what we actually observe in the interaction between what we would like to have for healthcare and what we actually produce. So understanding those factors. And then down here, an area that I'm sure is very close to all of your hearts, health economics can help inform the budgeting and the planning processes, can design appropriate and efficient monitoring mechanisms. One of the big things that I work on currently is when we decide to fund a new expensive technology because it's valuable in its entirety, how do we set up monitoring processes to ensure that what we think we buy is what we get? Do we observe the cost savings through shorter lengths of stay in hospital? Or do we just get all the upfront costs for the new test and the new drug, but don't get those cost savings? How do we design and implement good monitoring mechanisms? So that sits in there. And then there's the evaluation at the whole system level. Are we providing the healthcare that we want to the people that we want to provide it to? We have a fantastic healthcare system here in Edmonton. We have a fantastic healthcare system in Calgary. It's everything pretty much you could want in the world is here. I'm not sure that if I lived in rural Alberta, I'd be able to say the same. okay? And there's a whole area of system-level evaluation and a whole box of tricks. So the scope of health economics, where health economics can be useful to you, is much, much broader than just the evaluation at the treatment level. And I'd encourage you to reach out to health economists and ask us and challenge us to be as helpful to you as we can, whichever of these boxes your daily work life lives in. We should be helpful to you. Okay, so don't hesitate to reach out. If we don't know somebody who knows, we probably know someone who does know somebody who knows. We can find you the experts if we're not the experts ourselves. So please, as you learn more about health economics and what it can offer you, reach out to us because we want to be your helpful partners. So, stepping back, what is opportunity cost? Okay, so I take this as a kind of a fundamental, not up for negotiation fact. Since someone popped out into space and took this photograph, the idea that we don't have limited resources is no longer up for debate. We only have one planet. We have all of the resources that are in that. We have all of the talents and the skills of the people who live on it. But fundamentally, our resources are limited. And everything we observe about human behavior tells us that our ability to consume exceeds the capacity of those resources. So this is how many Earths do we need if we continue consuming in the ways that we observe different countries to do. So if we consume like Kuwait, we kind of need 5.1 Earths. USA, just under 4. Canada, about the same, 3.8. Trinidad and Tobago. There's nobody who's consuming at 1 Earth or less. What that tells us is we cannot have everything that we would like. Our resources are not sufficient to meet all of our wants. And that means we have the fundamental problem of scarcity. And opportunity cost is possibly the most useful insight of economics as a discipline. It's the idea of how do we get the most out of what we have? How do we choose? When we can't have everything, how do we choose what to have? Well, it seems sensible to me as an economist that we want to minimize what we give up. We want to maximize the value of the things that we do get from how we spend our resources. And opportunity cost is the principle that allows us to decide whether we are acting in line with that objective. The opportunity cost of choice A is the next most highly valued use of the same resources that we have to consume if we're going to have choice A, okay? And we want that to be as low as possible. In totality, the value of what we give up, we want to minimize. And if we ever make a choice whereby the value of what we give up is greater than the value of what we gain, we know we've made a bad decision. Okay? That's the simple, motivating insight of an awful lot of economics and health economics. So yes, if opportunity cost is greater than the value we get from A, we've definitely made a bad decision. And it's quite frightening how often we make those sorts of decisions. There's an idea called buyer's regret. And what we actually get isn't what we hoped. And we go, oh, I do that in my personal life way too often. But obviously, central to that idea of opportunity cost is what's value? How do we know the value? At an individual level, it's relatively simple because it's the satisfaction or the utility, use the technical term, that the individual receives from the consumption of the resources. What is valuable to me and what is valuable to you are likely very different. Once we've dealt with, food, drink, and shelter, the things I value are probably very different from the things that you value. And that's fine because you're spending your resources and I'm spending my resources. But how does that work when we're spending pooled social resources? We've all made our donation to the pot through the tax, and now, as a society, through government, we are spending that. How does that help? How do we understand what value is from that working on behalf of society, working on behalf of the taxpayer's perspective? If we knew what everybody valued, or we could just aggregate everybody's values. But we'd have to know even more about everybody than we already do, and people don't like that sort of level of intrusive government. So in practice, what we assume is our government, who we elect democratically, they express our values for us. And if they do something that really offends our values, we'll get rid of them next time round. And so this sets us in a very specific space in health economics, which is called the social decision-making framework. And essentially, we take the view that the government sets objectives for social agents, so the health system, the welfare system, the economic development ministry. They're agents of government, and government works on our behalf. And the government gives them objectives, and those objectives basically are expressions of things we value. And the more a government agent fulfills that objective, the more valuable what it does is, okay? So that kind of makes this a tractable problem from a decision-making perspective. Not only for theoretically, we have problems with the aggregate everybody's individual values perspective, because a very smart man called Kenneth Arrow established that it was logically impossible for us to identify an agreed upon social welfare function, something that we would all vote for. So that also pushes us into this social decision-making framework. And essentially, we're assuming that the policy objectives identified by government are expressions of what we value, and the more we achieve those, the better. Okay, so that's the end of a little bit of theory about economics. No more theory for you, really. Now this really important thing I already alluded to. So what's the difference between hypothesis testing and decision making? Anyone got a view? No? You can't not make a decision. I can choose not to test a hypothesis. I can say, well, I'm just going to go with the world, my understanding of the world as it is. I'll not do that piece of research. I won't test that hypothesis. But if I choose not to do A, it means I'm going to carry on with the status quo. And that's a decision, because that will involve spending resources. Okay? So doing nothing is not a decision. Not a decision. It's a decision to continue with the current way we spend our resources, which have costs and benefits. Why does that matter? Well, let's think about what we do with hypothesis testing. So, imagine we've got two treatments, A and B, and we're interested in looking at their mortality. And basically, if the probability that the observed difference between A and B is due to random chance exceeds 5%, we say, actually, there's no difference between them. That's how we treat it, okay? That's that P 0.05. Yes?
Dr. McCabe, do you mean if that's a p-value, would it be less than 0.05?
For it to be significant, it will be less than 0.5. But for us to say, well, we're saying they're not different, it's greater than 0.05, okay? I've turned it round a slightly different way because of the way I phrased it, but you're correct in your insight, yes. So we're just going to say if it's great, if the chance that it's just random variation is greater than 5%, we're going to say there's no systematic difference. It doesn't matter whether you choose treatment A or treatment B. Okay, now it's you. It's a choice. They cost the same. They have the same side effect profile. They're both tablets. You need to be treated, or you will definitely die this month. So this is a decision with real implications. And this is what the evidence says. It says that 12-month mortality on treatment A is 56%, and 12-month mortality on treatment B is only 45%. And the probability that this observed difference is due to random chance is 12%. Who's going to toss a coin to see whether they get A or B? Who's going to choose treatment A? Why are you going to choose treatment A?
If I'm doing it, I'm assuming we're doing it as an individual choice?
Yeah, this is your choice. So you've got a 56% chance of dying.
Chance is better with A. Oh, I'm sorry. I misinterpreted the question. I want to live longer.
So who wants to live longer? And who would use this evidence if this was the only evidence they had to choose treatment B? But look, there's a 12% chance that this is just random chance. But we're not testing a hypothesis. This is our lives, and this is a real decision. And that 1 in 20 threshold is suddenly demonstrated as being really quite arbitrary and not relevant to a decision. A hypothesis test, we're changing what is understood as being fact in the body of scientific knowledge. So yeah, we want a very high threshold. We really want to lower the risk that it's just random chance before we change what we think of as true. But when it's a decision, well, I don't know that this dichotomous approach to uncertainty is appropriate. The more important the payoff, the more I'm going to worry about uncertainty. But I'm not going to buy into an arbitrary 1 in 20 chance before I will treat this as being equivalent. A hypothesis and a decision are different, and the way we deal with evidence and interpret evidence should be different. Okay? For decisions, we use the expected value because we can't not make the decision. And the better expected value here is treatment B. Okay. So introducing economic evaluation. Very quickly. This is to just demonstrate how we really do use opportunity cost. It's not just this concept. So what is economic evaluation? Well, I'll kind of tell you what it isn't. And again, one of my hobby horses. When people present a cost analysis and say, this is what it's going to cost, and they say, we've done an economic evaluation. No, you haven't. An economic evaluation is a comparative analysis of 2 or more alternative courses of action. So you are looking at the difference in costs and the difference in outcomes. And you're asking the question, how much extra do I have to pay for each additional unit of outcome, of unit of value that I get, okay? If it's just a cost analysis, it's not an economic evaluation. Even if it's a cost comparison, it's not an economic evaluation, because you don't know how much something is worth until you know what you get for it. $1 million that gives you nothing is bad value. $1 million that saves 5 lives is good value. So an economic evaluation that doesn't report the differences on costs and outcomes of alternative courses of action is not an economic evaluation and is of very limited use. because there's always the do nothing, no change, which has cost and outcomes implications. And then there's the alternative. So there's always a comparison to be looked at, and there's always cost effects and outcome effects, and you need to look at both. We need economic evaluation because of scarcity, and it allows us to ensure that the benefits of the programs that we do implement exceed their opportunity costs. The World Bank describes it as a mechanism for targeting resources to their greatest effect, and that's the best neat summary of what economic evaluation does that I've encountered. There's three different forms. There's cost effectiveness analysis, where the outcome is a clinical unit, what the doctors would recognize. There's cost benefit analysis, where we put a monetary value on health and lives, which people kind of get uncomfortable with. Cost benefit analysis on building a bridge, all good. Cost benefit analysis on should we pay for this person's healthcare, people get a bit uncomfortable about being asked to put a monetary value on someone's life. So it tends not to be used. And then there's this thing called cost utility analysis, where we're interested in the life expectancy gains and the quality of life gains. So we use this thing called the quality adjusted life year, and we're interested in the additional cost per additional quality adjusted life year that is produced in order to make the decision about whether something is good value. How do we use it? So imagine we have a really nice small healthcare system, and we can rank the technologies that are covered by that healthcare system according to how much health they produce per $1,000 spent. So I want to ask you to buy into a value judgment now. An intervention that produces more health per $1,000 spent is better value than one that produces less. Everyone happy with that idea? I mean, it's a value judgment. I want you to take it on knowingly. The other thing I want you to accept is that the budget is increasingly clearly limited. We're not going to see big increases in the health system budget. We're closing in on 50% of the public expenditure. We're probably going to struggle to get it much higher than that. So we have a fixed budget, and we have this selection of technologies, treatments that are provided. And here is the least valuable technology. And if we want to adopt something else, this is the one we should give up. The least valuable thing. So that's a decision rule. Does that seem a sensible decision rule? If I want to adopt one of these ones over here, the first thing I should give up is this. Does that seem sensible? Yeah? So that's our opportunity cost rule in practice. Okay? Now, there's always technologies that people would like us to pay for that we don't. And there's the easy ones, well, they should be easy, which are worse than the current and which we should easily say no to. We know in reality even those are very difficult to say no to, but in principle, we should say no. These ones are better. So we should accept those, so let's do that first one. Now look, something really important just happened. Somebody's healthcare just got displaced. Okay, so if you take nothing away from this lecture but the following phrase, I will be happy. It's not money, it's somebody else's healthcare. Money is just the way we move healthcare around different parts of the population. So when somebody says, my life is worth that, yes, it is, and so is everybody else's. So it's not money, it's somebody else's healthcare. It doesn't mean it's the wrong decision, it's just not, let's not pretend it's about money. This one, still better than this, so we'll have that. If the budget doesn't increase, look what's happened. The value of the least valuable thing has increased, so future technologies will have to be even better. The cost per quality they produce will have to be lower. Instead of $50,000 per QALY, maybe they have to do $35,000 per QALY to be good value if the budget doesn't increase. But more importantly, look what we've managed to do. We have managed to increase the amount of health we produce from the same budget. And that's why it's the ethical thing to do. And this is all guided by consideration of opportunity cost. Those of you involved in the world of HTA, that box E, the microeconomic evaluation, will recognize that this here is the cost effectiveness threshold. Okay? That's what it is. It's the estimate of somebody else's healthcare. And then we see we've increased population health. But that little model schematic assumes that we're certain, okay? And the reality is we're not. Every time we make a decision, there's a risk that it's the wrong decision, that we don't get what we expected. And we can put a cost on that. So, the cost of making the wrong decision is the value of the benefit foregone plus any additional costs incurred, okay? And the expected cost of the wrong decision is simply that times the probability that we turn out to have made the wrong decision. If this wrong decision was costless, uncertainty wouldn't matter, but it's not. This is called a cost-effectiveness acceptability curve. And it simply plots the probability that something is cost-effective, so it's the amount of health it produces per $1,000 spent is more than the least valuable thing we currently do, for any given cost-effectiveness threshold. So here, with this technology, there's a 40% chance that it isn't cost-effective. There's a 40% chance that we've made the wrong decision, okay? Where do we get that? So we get the 40% chance, and we multiply that times the value, this opportunity cost, the cost-effectiveness threshold, because this is what we'd have lost. The thing we gave up inappropriately tells us the value of making the wrong decision. Get rid of that, sorry. The expected total cost of the wrong decision is the probability of making the wrong decision, the value of the health forgone, so the cost-effectiveness threshold, times the number of people affected by that decision. So how many people have the disease of interest and who have lost out. So I'm going to give you a little illustration to walk you through the idea. In reality, we're always uncertain. We don't know which state of the world will occur. But momentarily, with all due modesty, I'm going to assume omnipotence, omniscience, and say, I actually know which state of the world will occur. If state of the world 1 is going to occur, what will happen is treatment A will produce 9 QALYs and treatment B will produce 12. If state of the world 2 will occur, treatment A is now better than treatment B because it produces 12 QALYs versus 10, and you can go down. Now, when we don't know, when we're not omnipotent, we use the expectation, our best bet. So here, because treatment A is expected to produce 13 QALYs, having accounted for all the costs, netted those out, and treatment A only 12, I would choose treatment B in my usual decision-making perspective. But what if I could always know what was going to happen and make the right choice for each state of the world? Well, state of the world 1, I'd choose B, same choice, and so I wouldn't lose any health. There wouldn't be a cost. State of the world 2, I'd choose state of the world A. I'd use, option A. And this would improve population health compared to the expectation by 2 QALYs. And you go down. So what this shows here, we've got 5 states of the world. And if I was omnipotent and omniscient, I would always make the right decision every time, producing 13.8 QALYs on average versus 13 QALYs. And so I'd have improved population health by 0.8 of a QALY on average per person. So that's a state we call perfect information. If I had perfect information, so the maximum loss associated with uncertainty is this 0.8 of a QALY. Yeah? Because if I was certain, I could only improve things by 0.8. So that's with current information, so as we really are, 13. With perfect information, 13.8. And the loss associated with not with imperfect information, or the value of perfect information, is this 0.8 of a QALY. And that's the maximum value of certainty. We call it the expected value of perfect information. So in this example, the value of the health foregone is 50,000. The amount foregone is 0.8 QALYs. The affected population is 1,000 patients. The value of being certain about the decision is 40 million. If you could do research that would make you certain of which state of the world was going to occur, it would be worth spending up to $40 million on that research. Okay? So why have I done this? Really just to illustrate that uncertainty has a value, and health economics can help you calculate that value. And by extension, calculate the value of any research that reduces that uncertainty. Sometimes the uncertainty is so large, it's appropriate, I'd even go so far as to say ethical, to delay the decision for more research. Because remember, it's not money, it's somebody else's healthcare. So the summary, health economics. First of all, we're not just economic evaluation, even though the moment I told you that, I jumped into a whole load of economic evaluation-based illustrations. As a discipline, we're concerned with choices when resources are limited, which, by the way, is always. I wish it wasn't, but it is. Therefore, we consider scarcity through opportunity cost. Economic evaluation is one way in which health economics can support health policy decision-making. Remember, we want to help you with decisions. I'll test hypotheses when I'm in my ivory tower, but when I'm working with you, I want to help you make decisions. And that means I think about the evidence in a different way, and it is appropriate to do so. And that way of thinking allows us to evaluate opportunity cost of different decision options, including decision options where you say, we're not going to make the decision now. We are going to delay to get more information. And that is something that we can provide you with the evidence to justify, or indeed, when some people are saying, you really mustn't do this, we don't know enough, to explain that actually, yeah, we do know enough. And it would be inefficient and unethical to delay making the decision.